I'm going to give you a time frame, a guideline, a proper framework. I will guide you if any kind of audit comes that you have to audit a certain scenario that GBS is increasing, shoulder dystocia increasing, how will you apply that particular scenario in audit cycle? Be with me. I'll take your 1 hour at least because it's like almost 18-20 slides. But trust me on that. If you would be with me for next 1.5 hours, I can guarantee you, you will be master in audit. So let's start with audit. Now, what is clinical audit? Just memorize this definition. By any chance, if it is a teaching task, by any chance, if your examiner asks what is clinical audit, it's a structured process to continuously evaluate and improved care received. Sorry, there's spelling mistake of received. V is missing. Improved care received by the patient. So what is this? Clinical audit is a structured process. This is continuously evaluate. This is not a one-time process that 3 times in a year. It is a continuously evaluate and improve care received by the patient. So just divide this definition in 3 parts. A structured process. Number 2, continuously evaluate and improve. Continuously evaluate and improve. This is second part. Third, care received by the patients. It is one of the 7 pillars of clinical governance. So this is clinical audit. It is quality assurance process. It is the way to ensure we as healthcare providers are doing what we are supposed to do. I repeat, it's a quality assurance process. It is the way to ensure we as healthcare providers are providing what we are supposed to do according to principles of evidence-based medicines. Okay, just a minute. Okay. So it is the way we as healthcare providers are doing what we are supposed to do according to the principles of evidence-based medicine. It is also the way to find out deficiencies in our services. So first we'll talk about the clinical audit definition, and definition is divided into 3 parts. That is, first, structured process. Second, continuously evaluate and improve the care received by the patients. It is one of the 7 pillars of the clinical governance. This is definition. Then second, it is quality assurance process. It is the way to ensure that we as healthcare providers are doing what we are supposed to do This is so simple that we ensure as healthcare provider, we are doing what we are supposed to do to according to the principle of evidence-based medicine. And this it's also the way to find out any deficiencies in services. So audit, first, we come to know whether we are doing according to the principle of evidence-based medicines, means according to principle of NICE guideline, GTG, TOG, SIP. And second, audit also helps us in knowing our deficiencies in our services. So it helps us in two ways. It gives us assurance that we are doing perfectly. It gives us real deficiencies in our services, because basically audit is meant for quality assurance. Audit is meant for the purpose of audit is quality assurance, right? Next. Now, type of clinical audit. This may come as if you are teaching, then your student may ask, your junior may ask, what are the types of clinical audits? So there are three types of clinical audit. First, measures of structure or service provision. Second, process measure. And third, outcomes. Measure of structure or service provision. Structure means whatever infrastructure you are having as a hospital. Service means whatever services you are providing. So that audit first we do for measure of those structure and service provision. Evidence shows outcome of ovarian cancer is better if operated by a gynecologist and managed within MDT. An audit of referral and management of patient with ovarian cancer evaluate the service provision. So they have given an example that how we do the audit for the structure and the service. For structure, how we do? If ovarian cancer is operated by a gynecologist within MDT in a proper hospital care, then the chances or outcome is better. And an audit of referral and management of the patient, if it means how is the GP referring the patient, whether GP is referring it on time. So this is the management of structure and service provision, means first, whether the GP is referring on the time. Second, whether it is being handled by a gynecologist in an MDT, in a hospital. So this is the measurement of structure and the service provision. This is the very first type of clinical audit. Second is the process measure. Erythromycin improves neonatal outcome in PPROM. Evaluation of this process of care would entails measuring the proportion of appropriate women who receive the erythromycin. So process measure is what? That giving erythromycin is always helpful in neonatal outcome if there is premature rupture of membrane. Evaluation of this process will eventually help in the measuring the proportion of women who have received. So first step is that taking erythromycin is always helpful in neonatal outcome with the premature ovarian, premature leaking. Then second, it will be associated how many women have received that. So audit will include these two parts. So this is the process measure. Third is the outcome. Outcome, any procedure, any medicine, any surgery, any research, outcome can be desirable. Outcome cannot be desirable. Desirable means cure rate following the treatment X or patient satisfaction. Or see, cure rate following the treatment, any X treatment you are giving, or you are measuring the patient satisfaction. So that is very good. So that is the desirable. And what is the undesirable treatment? That after giving treatment Y, there were many complications. So here we are comparing the outcome. There is one condition and there were two treatments were planned. One is the treatment X and second is the treatment Y. Desirable was that after giving treatment X, patients were very happy. They were very satisfied because their conditions were improving. But with the treatment Y, patients were not happy. They were not satisfied and They got more complication rather than relief. So outcome comparison is again with audit, whether for a particular condition, if we decide two kind of treatments, then we do the audit just to see the outcome. Then we find that the treatment X is desirable, patients are happy. Treatment Y is not desirable because there are many complications, and so the patient satisfaction is very, very poor. So these are the T types of clinical audit. It may come in teaching. Your junior may ask, what all kind of audits we do? Answer would be same. What all kinds of audit we do? We do three different kinds of audits. First, structure and the service provision audit. Second, process audit. Third, outcome audit. So basically there are three types of audits: structure, service audit, process audit, and third is outcome audit. This is just, you just remember that, you just note down that, because if your junior asks, you should not be blank. Now, clinical audit is a loop. This is one thing which is very important, because mostly I've seen that when any student talk about steps of clinical audit, they do not complete the loop. If you do not complete the loop, your clinical audit is insufficient, inefficient, and not correct. So how you complete? Each loop is completed to improve healthcare provision. Further, therefore, not completing make the audit pointless. As I told you, if clinical audit loop, it's a loop. If you do not complete it, performing any kind of audit is useless. You get the complete benefit of any audit if you complete that loop. So each loop is completed to improve the healthcare provision. Further, therefore, not completing loops makes the audit pointless. If your junior asks you, or if your examiner asks you why it is so important to complete the loop, it is important to complete the loop to improve the healthcare provision further. Because incomplete audit means you have done for few first 4-5 steps, but later 2-3 steps which were very important, which I'll discuss. Normally, why loop is incomplete. So if you do not take those 2-3 steps, your audit cycle becomes incomplete. Your audit cycle loop becomes incomplete. So the advantage of that audit becomes incomplete rather than it becomes pointless. So if your examiner or your junior asks why it is important to complete the audit, you have to say that clinical audit is a loop. Each loop is completed to improve healthcare provision further. Each loop is completed to improve healthcare provision further. Audit we always do to improve your services structure-wise, service-wise, outcome-wise in future. Whatever has happened in past, you cannot repair that. Purpose of auditing is to improve your healthcare in future. So each loop is completed to improve healthcare provision further or in future. Therefore, if you are not completing loop, you are making audit pointless. This should be your reply. Now, steps of audit. I'm sure all of you are aware of steps of audit. The very first is the identify the issues. Probably that would be your task. Second, define the standards. In standard, I'll let you know how we define the standards. Third is the collect data. We have to collect data. Whatever situation has happened, whatever scenario has happened, we will collect the data of that situation, maybe going in past or maybe doing something in future. Then compare the performance with standards. So whatever data you will collect, you will compare with the whatever the standard rules. Whatever is the standard rules, you will compare your performance with the standard rules. I'll just give you a very basic example, right? Your mother-in-law have given you a task to make a very good potato curry. She has given you recipe. She has prepared once that in front of you. Now she has given this task to 3 daughter-in-laws. Okay. Now you are going to perform, or you are going to cook this potato curry separately or individually. All 3 daughter-in-laws or daughters are going to prepare that potato curry. Then your mother-in-law will sit and she will taste all 3 potato curries and she will say, this one is, A is very close to what I've made. B is deficient in this thing. So you need to improve, you need to fry it more, or you need to add salt more. Third, potato curry number 3, this is not close to my curry because this is deficient in this point, this point, this point. So you have to improve in all these 3-4 points. Then I have given you the recipe. I have taught you that where you did the mistake in making your curry. We will do it again after a week. And I'm giving you a week time. Just improvise yourself. Think multiple times. How did I make it? What all mistakes you have done? And try to improve that. Then again after 7 days, she will ask all 3 to prepare it again. Then again she will check who is close to her way of cooking that potato curry. Then that audit would complete. If she, on the very first incident, if she says that, okay, you have done this, A is very good, B has done this mistake, C has done this mistake, now I'm not going to do anything further, that is the incomplete audit. Complete audit would be then again after 7 days, she will again ask everyone to prepare same curry, and then again she will give her feedback. Okay, this is close to me, this has improved, this has still not improved. It is as simple as that. Audit again appears as a big fear to all of you. Trust me on that. Audit is again a very, very simple scientific method to check how your services are there. Only thing is that you have that fear. So these are the steps. Identify the issues. That is mostly the task which they will give you. Second, define the standards. That is any GTG, NICE, whatever is available for that particular task, you have to choose that. Third is the collecting data. Fourth is the compare the performance with the standard, because now you have data, now you have standard. So what should be the next step? Definitely comparing 2 with 3. You will compare 0.2 with 0.3. Then fourth, whatever performance you have compared, whatever shortcomings was in potato curry, your mother-in-law will tell you, okay, please implement these changes whenever you prepare your potato curry. Implement these changes. Put this much salt, fry this much, do this, take boiled egg, take boiled potato, something like that. So these are the implement change. Last, she will do the re-audit. She will again ask you to prepare it after 7 days. Then we'll come to know, okay, now whether Pushpa is perfect in preparing that curry or not, whether Shaheen, whether Shaista, Shima, Hebaz, Manikam, whether they are close to that potato curry or not. As simple as that. So, are you clear about steps? Girls? Anyone who can mute herself? I try to make it as simple as possible.
Yes, thank you.
Lovely, ma'am.
Lovely. Now you never forget this potato curry?
Ma'am, nobody has taught like this.
Who is this?
Come, ma'am.
No, it was you who said this. Nobody has taught like this.
Me only, ma'am.
Okay. So, am I clear so far, girls? You may find me funny at times, but this is how I teach my student. Whoever is like finding it a little bit weird, but this is how I teach all my students. So, just a minute. There are a few girls who wants to enter. Just a minute. Just a minute. Okay, so now moving further. Okay, so I'm clear about the steps of audit, right? Now, next, the very first step, that is the identify these issues, that is the selection of topic. Normally, you will be given that topic that you have to make an audit about the increasing cesarean rate. You have to make an audit why shoulder dystocia has increased. You have to do an audit why there is so much of GBS in babies. You have to make an audit why there is more instrumental deliveries or more perineal tear. Why there are so many perineal tears is happening in that particular hospital and you are noticing in your maternity dashboard. So that is the identify the tissue or the issue or cell selection of the topic. So here I'm taking my task to perform audit for LSCS in hospital about which is 32% and operative deliveries, that is, I mean to say instrumental delivery, just to be more precise, instrumental deliveries about 4%. So this is the task. This will be given in your task that you are ST5. You have to meet your examiner in a while because you are supposed to perform an audit for LSCS because maternity dashboard is showing that cesarean has increased to 32% and instrumental delivery is about 4%. So this is your topic for audit. Why it is important to see, it's not like that you are going to do an audit for every other topic. No, that topic has to have some relevance. That topic has to have something very important which needed to improve. Like LSCS, normally what is the national cesarean rate in UK? That is 21 to 26%. That is 1 out of 4 women going into labor, they are okay if 1 woman have cesarean and 3 women according to them should deliver normally. So it is around 25% approximately. And they want operative delivery around 10%. Rather than jumping directly to cesarean, they believe that we should try instrumental delivery. So the task was given that instrumental delivery was 4% and cesarean was 32%. Ideally, instrumental delivery should be around 10%. It should be more. Obviously, when instrumental delivery would be more, there will be decrease in the cesarean rate because you are performing cesarean in certain situation where you can do instrumental delivery. So task is this. So you are going to address it that way. It is important to achieve cesarean rate compared to the national cesarean rate, that is 21 to 26%, and operative deliveries or the instrumental delivery 10%. I can see on maternity dashboard that cesarean rate has been increasing and can see different indication for which cesarean was performed. So this you have to utter when you will presenting the task in front of your examiner, that my task is to perform an audit for LSCS in hospital about 32% or whatever percentage they have given. It is important to achieve cesarean section rate compared to national cesarean section rate, that is 21 to 26%, and operative or instrumental delivery 10%. I can see on the maternity dashboard because they will give you, there will be one task template and there will be one paper for maternity dashboard where they are going to give you maternity dashboard where they'll give you red, amber, green, and they would be writing that cesarean section. They would be writing the indication as well. You have to be very fast in reading that maternity dashboard. So we'll see that and we'll say that I can see on the maternity dashboard cesarean section rate has been increasing and can see different indication. They might have, they might be mentioning there that it's a VBAC failure, it is breach, it is malpresentation, it is second stage cesarean section, it was pathological CTG. So for pathological CTG, suppose in October they have performed 10 cesarean section for pathological CTG. For malpresentation, they have performed 15 cesarean. For previous cesarean, they have performed 10 cesarean. For maternal request, they have performed 12 cesarean. So they will give this way that these are the indication and for which how many cesareans they have performed. So what is the percentage? So indications like Maternal requests like breach, like malpresentation, like previous cesarean, like pathological CTG. Then 10, 20, 50, 30, they will give the number. Then next and last, they will be writing percentage, like total 32% or 35% cesarean being done in October. There were 3% or 4% instrumental delivery being done. So you have to mention that maternity dashboard. This is how you are going to address the very first step. It is not that step is given, so you'll directly move to second step. No, you have to elaborate the first step, that is identify the issue. That issue is already being provided, like this is this. Then you have to say this much line whenever you talk about the very first step. You cannot jump directly to second step. Now, second step is making audit team. This is going to be universal for every task of audit. The very first thing is going to be senior clinician who will lead the clinical audit. We call him or her project head. Second is going to be it's a clinical audit practitioner who can manage audit and support program, like registrars, trainees, consultants like obstetrician, pediatrician, gynecologist, midwives, GP. Bottom line is that all stakeholders. So making audit team, you are supposed to say only these two lines for almost all kind of audit team formation. Senior clinician who is going to be project head and who will lead the clinical audit. Number two, clinical audit practitioner means senior clinician subordinate who can manage audit and who can support program. So you have to learn two lines, who can manage audit and who can support program. So like registrars, trainees, consultant, midwives, GP, nutshell, all stakeholders. So first line is identifying the issue. Second step is making audit team. Third is define standard of best practice. So what are the defined standard of best practice? It is GTG, it is NICE, it is TOG. We can take even other hospitals protocols as well, or whatever MDT has decided for a particular condition. These are the defined standard which you have to take as standard or as base to compare with whatever we are doing. So basically, defined standard of basic practice is the potato curry which your mother-in-law has made. That is the basic standard of potato curry. So what you have been provided with, potato curry made by your mother-in-law, so you have tasted it and you have been given recipe for that. So that is the standard for making or preparing that curry. So that is the defined standard of best practice. That is, now here potato curry can be a GTG, can be a NICE, can be a TOG, can be other hospital protocol, can be MDT. And in the end, we are going to say, in particular for this task, I'm saying, as for this case, we would take NICE guidelines as standard. According to that, LACS should be 21 to 26% and instrumental delivery 10%. Right? So we'll mention that we take this. For this case, we would take NICE guideline as a standard. According to that, LACS 21 to 26% and instrumental delivery is 10%. As for this potato curry, we are going to take my mother-in-law's potato curry recipe as standard because we are going to compare with that only. Very simple. The first is the identifying the issues. Second is formation of audit team. Third is the defined standard of best practice. What standard you are going to take as best practice or as basic practice. Next is the data collection. This is a very important point because most of the buzzwords are in data collection. So please, everyone, listen to me very carefully. Very carefully listen to me. Okay. First, we would take permission from audit department to collect the data. because we are going to take permission from audit department to perform an audit. Because audit department is the very first department who is going to give you permission that you can do audit. It's not like that you just going there that I want to do audit and they'll give you permission. No. They will just go through the matter and they will see whether it is really important to do audit for this condition or this situation or this structure or this service or this outcome, or it is not required. So very first step would be take permission from audit department, then collect only essential data. As in cesarean section, we are not going to collect which background she belongs to. We are not going to collect what was her weight gain during pregnancy. We are not going to collect whether she was taking her antenatal visits properly or not. Here we are not going to collect all those data because that is not essential for the cesarean section increasing rate. So collect only essential data. It means that if you are taking any important news or any important data from a particular person about a particular person, it should not be irrelevant. It has to be which is important. Okay. So first we'll take the permission from audit. Second, only essential data are important to collect. Data can be prospective or retrospective. It is very easy. Retrospective means when you are going in past, you are taking cases, you are taking example of previous cases. Prospective when you are doing something in future. That is prospective. So retrospective, when we talk about, normally we take retrospective in a cases like shoulders dystocia, because shoulders dystocia is not so very common. And this is something which we have to look in past, why it has happened. What was the missing point? So a case like shoulders, normally what I understand, if there is any procedure, you should go always retrospective. But there is any medical condition, it's always better to go for prospective. Like if there is GBS, I would suggest going for the prospective. That we will look from now onwards for next 50 cases of GBS or next 6 months, how it happens, why it happens, where we are lacking. So as per my understanding, if there is any procedure or surgery, it's always better to take retrospective. If it is a clinical condition, if it is a disease, if it's a disorder, then it's always better to take prospective. If anything comes in your exam, you can take or you can tell on this basis that if it's a surgery procedure, immediately say, I'll go for the retrospective data. If it is a medical condition, then you will say, okay, I'll go for, say, if it is an ovarian cancer patient, right? So here I'll go for the prospective, that how many patients were seen by the MDT, how many patients will be going for the surgery, how many will go for the radiotherapy or chemotherapy. I will just study for 6 months, then I'll give conclusion that ovarian cancer is best treated by the MDT with radiotherapy. Chemotherapy was the second and surgery was not very helpful. So for any such condition, you always say that I'll go prospective. So retrospective and prospective, where you are going to choose retrospective, where you are going to choose prospective. I hope I'm clear, girls. Am I clear about that? Am I clear about that?
Yes, ma'am. Very clear,
Clear?
ma'am.
Okay. So how to choose prospective, how to choose retrospective? We have to go only for essential data. Retrospective. Now what? Both kind of data collection has own advantages and disadvantages. If we go with the retrospective, there is a risk of missing data. Definitely, you won't be able to cover all the patients. You won't be able to find sometime all the operation notes. Probably there won't be proper documentation of some cases. So in retrospective, there is always a risk of missing data. But the advantage is that is less time consuming, because you have to sit, you have to take the data of 6 months, and you can perform this audit very fast because you have all the data with you. You have to just give time to make a proper analysis of that. But if we go for prospective, The first very important side effect is Hawthorne effect. That is change in the behavior as aware of being observed. When the healthcare provider, they know that they are being observed, they are being monitored, they will try to act as close to standard as possible, because now they are aware of the fact. So what is Hawthorne? That is change in the behavior as aware of being observed, which is a minus point of perspective, because that is going to be misleading. If Dr. A was doing surgery for every previous cesarean section, now Dr. A is aware that my hospital is conducting an audit for cesarean section. So now Dr. A would be very alert, and Dr. A would make sure that for all previous cesarean, probably he or she will do VBAC trial. So whatever audit result will give us, that is not going to be actual picture, because actually before starting audit, that Dr. A was performing cesarean for every previous cesarean without giving a VBAC trial. So whatever result, whatever analysis, whatever data collection we get in audit, that is not going to be absolutely correct. That is going to be false, because the practice was absolutely different, which is now has been different, because now Dr. A is concerned that hospital is, or hospital management is watching me. Am I clear what I'm trying to say? So this is Hawthorne effect. But what is the advantage of prospective? There is no missing data, because for every patient who has gone for shoulder dystocia, we will immediately look into the operation notes, case notes, then and that, because audit is going on. So there won't be any missing data, but definitely there will be misleading data. There will be misleading finding, because everybody would behave very nicely. Everybody would very well behaved, because they know that they have been observed. And it is going to be time taking. Obviously, first, either you have to wait minimum for 50 cases, or you have to wait for 6 months. So you can do analysis only after 6 months. You can do the compare only after 6 months, once you will get complete data in 6 months. So it is going to be time consuming. It is going to have Hawthorne effect. The only plus point is that it is not going to have any missing data. That is the reason normally we prefer retrospective over prospective. These are the certain points where we prefer these because of these reasons. I hope I'm clear so far. Please, girls, be active. It gives me motivation. Girls, say, are you understanding what I'm saying? Because this
Yes,
is
ma'am.
okay. Okay, Manikam is understanding. What about other girls? It's only Manikam who is listening to me and understanding, right? What about other girls? Panas,
Yes, ma'am.
Likita, Shaista,
Yes, doctor, fine.
Yes, understood.
Yes, ma'am. Clear.
understanding? Shaheen?
Yes.
Okay. So should I go ahead, move further? And thank you, Manikam, for
Yes, ma'am.
always being so very active. It is really encouraging. So data which we have to take permission from audit department, we have to collect only essential data. These are the buzzword. You have to utter these words. Girls, these are the buzzword. We'll take the permission from audit department buzzword. We'll collect only essential data. Essential data is a buzzword. Data can be prospective, retrospective, buzzword. Hawthorne effect, buzzword. Missing data, buzzword. Right? Data Protection Act, another buzzword. Caldecott principle, which we have read a lot in part 2, that we need to maintain, need to take permission from medical record department. That is again a buzzword. Data Protection Act. We will follow Data Protection Act. We have to utter this word, Caldecott principle, because this is a buzzword. We need to maintain. Caldecott principle. We need to take permission from medical record department. So in this slide, audit department, essential data, prospective, retrospective, missing data, author effect, Data Protection Act, Caldecott principle, taking permission, these are all buzzwords. You are not supposed to miss that. So this is our next step. So how many steps we have covered? First, identifying the issue. Second, making the audit team. Third, define the standard best practice. Fourth is data collection. Next is the continued data collection. As I told you, data collection is the biggest step. Should give unique ID to patient. We call it as UIN, keeping patient name anonymous. Again, this is a buzzword. What? Give unique ID. That is UIN, keeping patient name anonymous. For all future references, UIN would be referred. Again, UIN, mentioning UIN is a buzzword because here you are mentioning about Data Protection Act because you are not relieving patient name. So saying anonymous patient, buzzword. Saying UIN, buzzword. Audit team, especially project head, would be responsible for data protection. Now sample size. It should be appropriate, like 50 cases or 6 months minimum. Again, this is a buzzword. So when you talk about data collection, you will talk about retrospective, prospective. You will talk about Data Protection Act, Caldecott principle. You will talk about UIN. You will say sample size. It's a buzzword. Sample size should be appropriate, like 50 cases or 6 months minimum. Data collection performer. Again, this is a buzzword. Where you are going to put all your data. There is a performer meant for that. If you have been given data that this much VBAC, this much breach, this much maternal requests, these are the data, how you are going to put it, where you are going to put it. You are going to put it in a performer. Means you are going to write the recipe of your mom-in-law. Here you are writing the recipe. Data collection performer. We call it as pilot performer. Again, that is a buzzword. If you do not utter this word, you are missing a buzzword. Data collection performer is a pilot performer for each patient. Pilot performer, you have to mention this word. Then another buzzword is pilot questionnaires. Should be simple and essential. It should not be a complicated performer because this performer can be filled by one midwife, GP, to consultant. It has to be very simple that everybody can understand this and everybody can fill it properly. So questionnaires are essential because without that there is no performer, but it has to be very simple. And data should be saved in Excel file or Excel sheet. Excel file or Excel sheet. Again, this is a buzzword. So in this slide, buzzwords are give unique ID to patient and keep patient name anonymous. So anonymous and UIN is buzzword. For all future references, UIN would be preferred. Audit team, especially the project head, is responsible for data protection. That is fine. Sample size, another buzzword. Should be appropriate, like 50 cases, 6 months. These two lines are buzzword. Data collection performer, another buzzword. Pilot performer, another buzzword. Pilot questionnaires, another buzzword. But pilot questionnaire should be simple and essential. You have to utter this line. And data should be saved in Excel file or sheet. That is also a buzzword. If you want to take picture of this slide, you can take. Now, again, we are continuing with the data collection for this case. Now I'm talking about for this case that cesarean section has increased. How we'll do the data collection and what all we are going to say. Our standard practice is the NICE guideline. that which is showing 21 to 26% and 10% operative delivery, and we have to try to reach to close to this data. We will go for the retrospective data. In retrospective data, we can take either 50 cases or we can take whatever has happened in last 6 months. Okay, so here we are going to, if you get this cesarean wala task, then you are going to say standard would be nice. Retrospective data is not going to be prospective, either 50 cases or 6 months. Missing data, to compensate missing data, we'll go through the OPD notes, especially OPD notes after delivery. Post delivery OPD notes को हम check करेंगे. We will check OPD notes after delivery. So that is very important. If we miss anything, but if we go through the OPD register post delivery, they have come for the checkup. We'll come to know about that that patient has cesarean for this reason, because they might be having the SHA summary with that. So by any chance, if you miss anything in your OT notes, if you miss anything in your operation theater list or your labor ward list, if you meet any patient, you can catch that patient in OPD list when they will come for their checkup post delivery. If you come to know that that particular patient has gone for cesarean, that missing data you can add. If you are going through only for operation notes or the labor ward notes to collect the data, right? Then performer should have primary and secondary indication. This only I'm talking about. If you get this cesarean, then how you are going to explain. So now you will take about that. We'll talk about the pilot performer, that will make a pilot performer. Then how will you make the pilot performer for a cesarean section? We will divide in two, that is the primary indication and the secondary indication, or the cesarean done for primary indication or the secondary indication, or the secondary you can say repeat. We will rule out the category 1 cesarean section. So this is going to be our exclusion criteria. Whenever we make any criteria, whenever we make or collect data, there is retrospective, there is prospective, and there is inclusion or exclusion criteria also we follow. So in cesarean section case, exclusion criteria would be primary cesarean section, category 1 cesarean section. So we are going to follow the knives. We are going to collect retrospective data, maybe 50 cases or 6 months. To compensate missing data, we are going to go through the OPD notes after delivery, operation notes, and the labor ward notes as well. Performer should have two kind of indication, like primary or the repeat, or secondary. You can say secondary or you can say repeat as well. I think repeat would be more appropriate. So it is going to be repeat. Then exclusion criteria would be not including any kind of category 1 cesarean, because category 1 cesarean, if you are performing cesarean for cord prolapse, that is the category 1 cesarean, and that is mandatory, so that cannot be questioned. If category 1 cesarean we are doing for the scar dehiscence, that cannot be questioned, because that was important to save mother and the baby. Here they are not compromising. Here they are not lacking anything. Here not deficient in services. That is a different situation. Category 1 is a different situation. So here I will put category 1 situation or cesarean as exclusion criteria. So retrospective, prospective, inclusion and exclusion criteria. So here category 1 cesarean is exclusion criteria, and my performer would be having primary and the repeat indication. Now in primary indication, there would be breach, there would be malpresentation, there would be pathological CTG, there will be cesarean second stage, there would be maternal request, there would be, and repeat cesarean section, there would be only VBAC trial offered. So my performer would be having two indication, primary and repeat. In primary, I will take these as indication and how many cesareans were performed for this. So this is how you are going to collect the data. Now next is the data analysis. Compare against standard, which is very simple. Whatever you have made potato curry, your mother-in-law is going to compare with her potato curry. So her potato curry is the standard and your potato curry is the analysis. So compare against standard. to assess performance against the pre-specified standard. This is data analysis, where we compare against standard. We call it as data analysis. Here we assess the performance. How I have made my potato curry, that is my performance, which we are going to compare with pre-specified standard, that is the potato curry made by my mother-in-law, my mom. So to assess performance, my performance against the pre-specified standard. This one line you have to remember, because this is again a buzzword. To assess performance against the pre-specified standard, that is the compare against standard. Now, how we are going to compare this? Why are we not achieving it? Are we achieving now? Like, if it is second audit or if it is re-audit, are we achieving now, or why we are not achieving? Means why I'm not able to make potato curry like my mother-in-law? Probably I did not fry it properly. I tried to make it early and I did not fry it properly, so it is not tasting as my mother-in-law's potato curry is tasting. Simple. So why I'm not able to achieve that kind of taste? That is the analysis. So why we are not achieving? Or again, after 7 days, again I'm making that, again I'm doing some mistake, or I have achieved the same taste which my mother-in-law was providing me. So data analysis, the buzzword is compare against standard. This is a buzzword, you have to utter this. Then why we are not achieving, or are we achieving now? Are we achieving now comes when it is about re-audit, not the first audit. Then there are two types of analysis, quantitative and qualitative. This is again a buzzword. You have to mention that data analysis, we are going to compare against the standard to assess the performance against the pre-specified standard, why we are not achieving certain targets. There would be quantitative and the qualitative analysis. In this case, like in the cesarean case, the quantitative analysis would be what proportion for each risk factors, and qualitative would be the increased cesarean section related to the shortage of consultants, staff monitoring, non-trial of VBAC and instrument, etc. So quantitative would be for each risk factor, what is the proportion? I mean to say, for malpresentation, how many cesareans? For previous cesarean, how many cesarean? For maternal request, how many cesarean? For second stage labor stage cesarean, how many cesarean? So these are the quantitative. That for breech, they have performed 10 cesarean. For previous cesarean, they have performed 15 cesarean. For maternal request, they have performed 18 cesarean. So this is quantitative. Now qualitative, why they have performed 20 cesarean in breech rather than doing external cephalic version. This is qualitative. Why? Because there was shortage of consultant, because there was shortage of training, where there was lack of training. Why pathological CTG and you did the cesarean? For pathological CTG, 20 cesarean being done. This is quantitative. But why for pathological cesarean, not the fetal blood sampling was done? That is qualitative. Why fetal stimulation was not done? Why fetal blood sampling was not done? This is qualitative. It means probably the trainee ST3, ST4 was not trained enough to perform a fetal scalp stimulation or fetal blood sampling. So this is qualitative. Quantitative is for pathological CTG, we perform 10 cesarean. This is quantitative. Pathological CTG, we did not perform FBS and FSS because trainee was not confident about it. So here you are going to say that in quantitative, what proportion for each risk factors, I've already told you. And for qualitative, what proportion of surgery or cesarean because of shortage of consultant, because of lack of training, because of wrong interpretation of CTG, because of poor monitoring by staff.
Mama,
Whose baby is this? This is Shaima's baby. Okay, no issues. Okay, so am I clear so far? Am I clear how you are going to talk about data analysis? This is going to be a very important task. Trust me on that. The way our college is going, audit can be a very important task in next exam, in FAB exam. Am I clear about data analysis? How you will say the compare against standard, which is a buzzword. Second is going to say why we are not achieving our targets. Third, we are going to say quantitative and qualitative. You will mention how you are going to do the quantitative analysis. That is proportion of cesarean section for each risk factor, how you are going to do qualitative analysis, that is shortage of consultants, shortage of training, lack of monitoring, and etc. etc. Then inclusion or exclusion criteria, that I've already told you, this is a buzzword, you have to mention it, inclusion or exclusion criteria. By any chance, if you get any other task and you are not able to find out that what should be your exclusion criteria or inclusion criteria, at least you mention that we will take inclusion or exclusion criteria while performing the analysis or while making the pilot performer. If you are not able to point out, as here we are able to point out that category 1 cesarean, we will take it as exclusion criteria, that we will not talk about it when we'll talk about increasing cesarean section, and we will fill the performer. We will not fill any patient who has gone for who has underwent category 1 cesarean. So if you are not able to find out, which is a possibility, at least mention that while doing the analysis, we will follow the, or while performing the, while making the pilot performer, we may include the, or we may take inclusion or exclusion criteria. This would be even enough because you are uttering the buzzword, that is inclusion and exclusion. But if by chance you are able to make any inclusion or exclusion criteria, that should be your discretion. It is not something that should match to the other student, because that is your way of doing audit, right? So you can choose your own inclusion or exclusion criteria. After data collection, IT department will spread in data sheets and analyze with standard. Simple. Now they have standard rates that for breach, they should perform this much cesarean. For maternal request, they should perform this much cesarean. For VBAC, there should be, in VBAC, what we have heard, that in VBAC, what we have read, 3 out of 4 women would deliver normally, 1 woman would be needing cesarean. So that is the VBAC standard, that 1 out of 4 women should go for the emergency cesarean, 3 out of 4 women should deliver normal. Now, this is the standard. Now, IT department, who has spread the analysis and the data in sheets, they will compare with our hospital. Okay, for in our hospital, for VBAC, 2 women went for emergency cesarean, or 2 women needed emergency cesarean, and 2 women could deliver normally. So we are not matching the standard. Standard is 1 should be needing emergency cesarean, but in our hospital, 2 are needing cesarean section. So that is the comparison. This is the standard and this is the comparison. So in data analysis, compare against standard, that is the buzzword. Why we are not achieving target? Again, a buzzword. Quantitative, qualitative analysis, you have to mention this, a buzzword. Inclusion or exclusion criteria, again, a buzzword. Then IT department spread in data sheets and analyze with standard, again a buzz line, you have to utter this. After that, continue data analysis and compare. So now here I mix 2 steps, that data analysis, then compare with standard. Analysis of data done and interpretation made in chart and graphs, that I told you. Right? Whatever analysis of data, whatever has been done in this hospital in past 6 months, how many cesarean, they will put in a chart of graph form. That's for breach, this much patient, for this much patient, for this risk factor, this much patient, for second stage cesarean, this much. It is so simple. This performance has to be very, very simple. It will be that simple only. That breach 10, second stage cesarean 5, and they will put in form of chart, like graph, 1, 2, 3 columns, and they are making a graph. Compare against standard. This again was what I've already told you. Then this will be discussed in audit meeting. Again, another buzzword. Whatever analysis has been made, whatever compare has been done, now this compare, this analysis you are going to discuss in audit meeting and should be arranged on less OPD days. So attendance would be maximum. So next is going to be, what is next? Buzzword, chart and graph. Analysis of data done and interpretation always in chart and graph. You have to, they have taken all data, they have made interpretation in chart. This is buzzword. We have to discuss in audit meeting, again a buzzword. Should be arranged on less OPD days, again a buzzword. Should be attended by all stakeholders and staff. All stakeholders means all obstetrician, all neonatologists, all pediatrician, all registrars who are posted in labor board or gynae registrar or registrar, ops trainee, midwives, nurses, etc., etc. You can mention all these. In nutshell, it is going to be all stakeholder. Saying stakeholder is again a buzzword. Less OPD time, again a buzzword. In audit meeting, again a buzzword. And to be notified in time and properly, again a buzzword or buzz line, I would say. A very important. While discussing the results or interpretation and compare with standard. Yeah, I know that everybody is aware of this. So while discussing the results and interpretation and compare with standard in three important buzzwords. I know you all are aware of these three buzzwords. Non-blaming culture, hard on issues, soft on targets. I am 100% sure every one of you are very much aware of these three lines. Non-blaming culture, hard on issues, soft on targets. So results or interpretation would be discussed in audit meeting. All stakeholders or staff should be there. We should do it on less OPD days. We should notify everyone in time and properly. And we should discuss results and the interpretation, and we should compare with a standard in a non-blaming culture or attitude, hard on issues, soft on targets. Would provide result in Excel sheet, would try to find out what went wrong. This is again buzzword. That would provide result in Excel sheet, right? Excel sheet. This we have already discussed here. That always is provided in chart and graph in Excel sheet. Is all we Excel sheet mein banate hain na, we always make this in Excel sheet. So we have to utter this word and we try to find out what went wrong, why something done or why something not done. Accordingly, recommendation would be made. Right? So discussing in an audit team meeting, all would be informed, involved, all stakeholders, less OPD day, all will be notified to attend the meeting, and we will discuss the result or interpretation and compare with the standard, non-blaming, hard, soft. Then all results will be in the Excel sheet. We'll go through it and we'll try to understand what went wrong, why something been done or why something not been done. And accordingly, we will make the recommendation. Only once we'll come to know about our mistakes, only then we'll try to improve that. When my mom-in-law told me that you have not fried it properly. So my first recommendation after 7 days, when I'll again prepare that potato curry, no, this time I will fry it for minimum 10 minutes. Because that was my mistake. So my recommendation is frying it for 10 minutes. So that I have come to know only about when I was told it that this is your mistake. So analyzing the result or the interpretation, what went wrong, why something been done, why something not been done. Accordingly, we'll make the recommendation. Accordingly, we'll make the recommendation. So, on the basis of comparison of analysis with standard, results will be made and discuss in meeting, and recommendation would be made according. The same thing I have written here. On the basis of comparison of analysis with the standard, whatever the analysis when with standard, whatever comparison is there, the result will be made, right? So there is analysis, there is standard, then the result is made, and result is made in Excel sheet. Result is made in Excel sheet. So first thing is your data collection. Second is the analysis on the basis of your data collection, whatever, how you are doing, whatever you're doing in the hospital, that is, they are going to make in a graph form this thing. Then they are going to compare with whatever standard they have. Then after your analysis, their standard, then equivalent to the interpretation or the result. Analysis, first column, second column is the standard, equal to result or interpretation, and result or interpretation would be in form of graph, chart, and in Excel sheet. Clear? And on the basis of result or interpretation, after comparing analysis with standard, whatever result or interpretation came, accordingly, we will make the recommendation. So this is, if you can memorize this line, on the basis of comparison of analysis with standard, result will be made and discussed in meeting, and recommendation would be made accordingly. You have to memorize this line. This is little bit difficult, but you have to. Like in this cesarean case, previous cesarean, thorough and ethical trial of VBAC. So these are the recommendation given after going through the analysis of 6 months case or 50 cases. And then we have compared with the standard, that is the NICE guideline. So our interpretation is, or result, whatever we got, we made these recommendations. That for previous cesarean, there should be a thorough ethical trial of VBAC. For second stage LSCS, there should be instrument application. For pathological CTG, we should perform fetal scalp stimulation or fetal blood sampling, and there should be correct interpretation of CTG. For breech, we should always offer ECV first. For cesarean section, for maternal request, we should tell her pros and cons. It should be seen by or addressed by 2 consultants. We should always think about the social factor, whether there is any kind of trauma she is going through, any abuse she is going through, any fear of losing baby. She might have lost her baby earlier. Tocophobia, that is the fear of giving childbirth. Vaginal itself is a fear for many women. For instrumental delivery, we will recommend trainings. We will recommend performing in presence of experienced consultant. So these are the recommendations which we made on the basis of whatever interpretation or result we found after the comparison of analysis and the standard. After the comparison of potato curry which you made with the potato curry made by your mom-in-law, now you come to this result or interpretation that you have not put the salt properly, you have not put the, you did not fry it properly. So recommendation would be, please fry it properly, please put salt properly. As simple as that. Analysis, you are doing so much cesarean for this. Standard is this, that you should do the instrumental delivery 10% overall, but you have done only 4%. Probably for every second stage labor, every second stage labor or prolonged labor, you are directly going for cesarean. You are not giving a trial of instrumental. Probably you are not going for VBAC. You probably are not doing external cephalic version. So that is the comparison with standard. To what is the interpretation? That for breech, they have not offered ECB. For previous cesarean, they have not offered VBAC. For cesarean section on maternal request, they have not bothered to address her concern. She said cesarean and they happily went for cesarean. So this is our interpretation, that they have not addressed mother. They have not offered ECB. They have not offered VBAC trial. So this is our interpretation. This is our result. So what would be the recommendation? They have not offered ECV. Our recommendation would be, please offer ECV. If you are not aware of ECV, if you are not properly skilled in ECV, just attend the training sessions of ECV. Skill and drill training sessions should be organized in hospital. if you are not doing the instrumental delivery, you are not confident about it, you should do again skill and drill training session and hospital conferences where they are teaching about it, or you should try to perform in presence of consultant. So recommendation on the basis of result, that they were not offering ECV, that they were not performing instrumental delivery, that they were not doing the fetal scalp stimulation, pathological CTG, they were directly taking to cesarean section. So recommendation would be so easy. Previous cesarean, VBAC trial, pathological CTG, do the fecal self stimulation, do the FBS, and do the right interpretation of CTG. So in the end, with this, you can write one more recommendation, that more training sessions, more skill and drill, more hospital conferences for external teaching, external cephalic version, fetal blood sampling, fetal scalp stimulation, CTG interpretation conferences, CTG interpretation training session should be there. CTG interpretation teaching session should be there. So these would be your recommendations. It is so very simple. Then continued recommendation. Recommendation should float. Ab aapne, you have made some recommendation in your audit meeting. But if you are not floating it, if you are not providing it to other people who are involved in the care, then it does not make any sense. So again, this is a buzzword. Recommendation should float amongst all stakeholders, not only doctors. It's a buzz line. Recommendation should float amongst all stakeholders, not only doctors, like amongst neonatologists, pediatrician, trainees, registrars, midwife, GPs, etc. And in form of how you are going to float this recommendation, in form of flashcard, in form of flyers, in form of mails, leaflets, intra-hospital conferences. Simple. Then implementation of changes. Obviously, now recommendation has been made. Recommendation have been made. You have been provided that these are the recommendations. But what if you are not implementing the changes? What even if after 7 days I'm frying my curry in 2 minutes and I'm not putting salt? Again, back to zero. So implementation of changes are very important. Implement changes according to recommendation. It is so simple. Putting clear plan of action in place. This is very important. You have got the recommendation, but how to implement that? How to proceed for that? Something is on paper and something which you have to do practically. There is much difference in that. So you have to do something practically. You have to make a clear plan of action. This is a buzz line, putting clear plan of action in place, and that should be simple and achievable. You should not make that I make a plan that you have to do 10 training session for ECV, then instrumental delivery in 1 month. This is practically not possible. So putting clear plan of action, that should be simple, that should be achievable. Fix a time frame, that is very important. As my mom-in-law has given me 7 days time, that Pooja, you have 7 days time, just make as many potato curries yourself as possible, because on day 7, when there will be re-audit, you have to make a perfect audit. You have to make a someone who is Salma Sheikh. Okay. That you have to make a perfect potato curry on day 7. So my fixed time frame was 7 days. For clinical audit, minimum we give 6 months to sometime 12 months. If you are not able to find out whether you have to say 6 months or 12 months, say the range. For cesarean section, 6 months are enough, because here we are not supposed to do a much, very tedious job, right? So here you can say 6 months, but in case in your task, if you are not able to understand, just say range, that re-audit, fix a time frame that is usually minimum 6 months, but clinical audit may be 12 months. So you can say 6 to 12 months. Monthly clinical governance meeting would be held. We will maintain the maternity dashboard and we will follow it. So this is how you are going to implement the changes. First, putting a clear plan of action, implement the changes according to the recommendation. So whatever is the recommendation, you are going to implement the changes. That if breach is there, You are going to offer ECV. Patient refuses, it's a different thing. But you are going to offer ECV. This is the change, implement changes. What change? Offering ECV. You have to offer VBAC trial. This is the change we have made. Recommendation was offer VBAC trial. So what change we have made? Now we offer every previous cesarean VBAC trial. We explain the VBAC trial in clinic itself, in antenatal visit. Was it VBAC trial? What are the advantages? What are the disadvantages? This is the implementation which we have made, or change which we have implemented on the basis of recommendation. And for that, you have to have a clear plan of action. What would be the clear plan of action? Your consultant head would tell you that you are ST5. If you are seeing any patient previous cesarean in your OPD, it's your duty to tell her what is VBAC trial, what are the disadvantages, what are the advantages, what is the success rate, what is the failure rate, and how we manage the complication. So this is the change which has been implemented, that your consultant has asked you to do the VBAC trial counseling for all previous cesarean. You will talk about the external cephalic version with all breech patients. You will offer them. This is the change which you have made. So what was the clear plan of action? That consultant has guided you that you have to do this. And whenever you are performing external cephalic version, either a senior midwife who is experienced with this procedure, or a consultant, or ST6, or maybe ST7 would be there. It's not the consultant always. Even ST7 can be there, and you can do under ST7 guidance. You can do under a very senior midwife guidance. You can do under a consultant guidance. So what is the change which you have to implement? That you are going to offer ECV. You will perform ECV, because now you have to be perfect in ECV. So do attend the skill and drills, do attend the training session, do attend the teaching session, do go through the study material video, and perform ECV in front of any senior experienced person who has full expertise in ECV. As simple as that. What is difficult in that? It is so simple. That implement changes according to recommendation. Putting a clear plan of action should be simple and achievable. If you say that your junior that you have to do ECV, you have to do it on its own, and you have to be successful in that. This is not achievable. It has to be achievable, that okay, you will try. Probably you won't be successful. There would be a senior person. If you won't be successful in the one go, then he may try in place of. But first trial you have to do. So it has to be simple and achievable. Implement changes according to recommendation. Putting clear plan of action in place should be simple, achievable. Fix a time frame. Fix a time frame, a buzzword. Putting clear plan of action is a buzzword. Implement change according to recommendation is a buzz line. Monthly clinical governance meeting, maintaining maternal dashboard and the maternity dashboard, and the following it. And I think this is the last slide then, re-audit. Here, this is the point which normally candidates forget to talk or forget to mention, that is re-audit. Do not forget to mention re-audit, because only after re-audit you are going to complete the loop. Only after 7 days, when you are going to make another potato curry, which is close to your mom's in-law potato curry, your audit is complete. That is re-audit, to be conducted after a set time, maybe 6 months, maybe 12 months, to complete the loop, to ensure clinical audit and the clinical improvement activities. If you cannot remember this much, just remember, to be conducted after a set time to complete the loop. This much is enough. To be conducted after a set time to complete the loop. That's it. Itna bhi bol doge, that would be enough. Re-audit to be conducted after a set time. Maybe 6 months, it may be 12 months. To complete the loop, this is enough. We would complete the loop by re-audit after 6 months to check whether we could meet this. I'm talking about our cesarean, how we are going to specifically talk about the task. This is generalized statement, to be conducted after a set time to complete the loop. This is a generalized statement. For the task cesarean, we would complete the loop by re-audit after 6 months to check whether we could meet close to the standard rate of LACS and instrumental delivery. So this is so simple. We have to mention just that we would complete the loop by re-audit after 6 months. We'll check whether we could meet close, or we could reach close to standard rate of LACS and instrumental delivery. Is it difficult to remember? No. And we could improve or not, or we could achieve our target or not. That would be a re-audit. If we could achieve our targets, so whatever changes has been made, we'll continue with that. Even after 6 months, we cannot achieve the target, then again there would be analysis, there again would be comparison, then again there will be result and the interpretation, then again there will be a meeting, again there will be new recommendation and the implementation. Re-audit is a very simple line. Generalized line is to be conducted after a set time to complete the loop. In context with this cesarean, you will say that we would complete the loop by re-auditing after 6 months to check whether we could meet or reach close to the standard rate of cesarean section and instrumental delivery, that is the 1 out of 4 and the 10%, and whether we could improve or not, or we could achieve target or not. So this is re-audit. Simple. Am I clear about audit, girls? I really tried hard to make very simple slides, which you can understand easily, because I know audit itself appears very difficult to everyone, which I personally do not find very difficult. I think it's not very difficult. Audit is a game of buzzword. Audit is a game of complete buzz lines and buzzwords. If you utter those words, you will through the task very easily. Audit is all about buzzwords. Audit is a very simple task. The only thing, you have to come out of your fear. I tried my level best to make it simple. Please give me your feedback. All girls, I would like to hear from all of you. Did you find that now audit is easy for you? Everyone, please unmute yourself.
Yes, ma'am.
Okay, Manika.
Yes.
Yes.
Very easy.
Shaheen, you find it easy now?
Yes, ma'am. Yes, ma'am.
Farnaz? Likita?
Yes.
Likita, so now
ma'am.
it's easy for you. Can you perform this task if it comes in exam?
Yes, ma'am.
Very good. And Pushpa? Saima? Saima, are you there?
Yes, ma'am, I'm there. I'm here.
Okay, Saima. So do you find it helpful?
But I joined by
You joined late?
yes, I joined late because of some commitment at my hospital.
Okay, so should I just show all my slides too? You want to take a pic of that, screenshot of that?
Yes, ma'am. Yes, ma'am.
Okay, so I'm just going through all my slides again. I'll just show you. Okay, so whoever wants to take the picture or screenshot, they can take. So this is my first slide. This is second one. Third. Tell me if I'm fast, okay? Fourth. Fifth. Sixth. Seven. Eight. Sleeping. Who is sleeping? Who is sleeping? Manika is sleeping, huh?
Hey, yawning, ma'am.
Okay. So should I move to next slide? Okay. Data collection.
Yes, ma'am.
Then continue data collection. This is slide number 12. This is slide number 13. Which one? 12? 12? This one?
Before.
This one?
Yes, ma'am.
Okay, this is 12. This is 13. This is 14. This is 15. This is 16. 17. 18, total 18 slides. So first slide, if you can remove, because that is just mentioning my name. Basically, there are 17 slides. Okay, anybody else who wants to take the picture or want me to?
Ma'am, slide number 2nd and 3rd. Kindly show the slide number 2nd and 3rd.
Ma'am,
இது
15,
பிச்சிருவேன்.
please. 15, 16,
Second.
please.
And third. Okay.
But with a unique identification number.
Okay, that one slide. Okay, wait. This one? This one, dear? That's all? Anybody else who wants any other slide?
Yes, ma'am. Thank you.
Okay, so that's all for today. And I would suggest do not take this exam for granted. This is my sincere suggestion for everyone. Do not think that we have still 3 months left. Trust me on that. The 3 months fly like anything. Do not leave anything for the last few days. Last few days is just for the revision, just for the relaxation, taking proper sleep, and just relaxing yourself. These 2 months, if you are appearing in FAB exam, this November and December are very, very, very important for you. Very important. You still have 10 days, you still have complete 31 days of December. Do not give any excuses to yourself that, okay, I have this work, so I cannot study today. See, if you're trying to give excuses to yourself, it is not going to help anyone. Reason being, at the end of the day, it's your exam, it's your money, it's your time which you are giving to your exam and your studies, and the time which your family deserve, which your kid deserve, which you deserve for yourself, right? So just do not fool yourself by giving lame excuses that, oh, I couldn't study because I was busy there. Reading, that's why the aim of my course, that MRCOG, was that only, that there is a compulsion of preparing minimum 1 to 3 tasks daily, and that compulsion puts you under compulsion of preparing whatever is the situation, because you have that compulsion that you have to prepare 3 tasks. And that was the principle of starting this course, because I have myself gone through this phase. I used to give lame excuses to myself. Okay, but yesterday I couldn't sleep because I was in delivery, so I cannot study today. Okay, it's fine, PUUJA. But at the end of the day, it did not help me, because I'm fooling myself. I'm not fooling to my mentor, I'm not fooling to my family, I'm fooling myself. So it is always suggested to at least prepare 1 to 3 tasks. And the MRCOG 10 weeks, I have that principle only, that you have to present minimum 2 to 3 tasks daily, whatever is the situation. For your help, study materials are there. For your help, there is proper answer key by myself. The way I have presented here, the proper answer key, maybe in audio, maybe in written form, you have for all the tasks. So say if you have to present, say, overactive bladder, you don't need to search it anywhere. Just go through the study material, go through my answer key channel, hear my overactive bladder, go through the voice template library, where you'll get minimum 5-6 voice template for the overactive bladder, complete task of 10 minutes performed by other good students. So after that, would you take time to prepare overactive bladder? No. Just go through the guideline, PIL, going through my answer key and voice library, your task is ready. So there is no excuse. You will present 3 tasks every day. There is no reason that you won't succeed in your exam. You are presenting tasks, 200 tasks to your mentor. You're getting, I'm very strict. I'm very strict by nature. My trait is being strict. So I'm very strict when I give feedback. I'm very strict when I follow my timetable. I do not give any chance of, any stone unturned. But that helps me in the end. That my students are able to present 200 tasks. Each student present 200 tasks to me directly. So if you are recording 200 tasks, which you have to present to your mentor, so you just imagine the level of practice you will get. So that is the principle of my AIM MRCOG 10 weeks course. Extended course I've already started in October, because that was for 16 weeks. That 16 week, that is not applicable now. But 10 weeks course, if somebody wants to take, they can DM me for that. There's one more course which I definitely want to discuss, because 3 students have taken last time, and I'm not boosting myself, but the feedback they have given to me, that was really, really encouraging. So earlier I was planning only for 3 unique MRCOG seats, but now I'm thinking that I'll go for unlimited, because the benefit they have got, according to them, this was their feedback, that those 50 recalls in unique MRCOG, basically 50 recalls, 1-to-1, you are going to present me directly in Zoom session. I will be your role player, and I will be giving you feedback, and we will be discussing answer key as well. You can take it on daily basis. You can take it as 3 station in a go, 5 station in a go, whatever is your choice. But mostly they preferred 5 station in a go. And I was so very happy when they say that whatever improvement they have shown only after this 50 recalls, because 50 recalls they have presented directly to me, discuss answer key, and for 5 or 7 station tasks, we used to have almost 3 hours Zoom session. For 7 tasks or 5 tasks, I was taking almost 3 hours. 7 tasks is around 70 minutes. That is 1 hour, 10 minutes. If you say the feedback, may further half an hour, 1 hour, 2 hours, but we were taking almost 3 hours every time for every student who were presenting 5 to 7 tasks. Reading, we were discussing everything in detail, how to present, how to be empathetic, when we have to offer counseling, what should be the timeline, what should be the sentences, how to say. We used to take good 3 hours in each session only for presenting 5 to 7 tasks. And at a time, only one student. It's not like that one student is presenting and rest are listening. No, it is absolutely exclusive, you and me. So there is no hesitant, there is no, embarrassment that, oh, somebody is listening, if I won't be able to perform, nothing like that. It's you and me, our Zoom session, our detailed discussion and discussing tasks. 50 recalls, one unique course contains 50 recalls. 50 recalls which you can choose as your choice, as your need, or if you want me to choose, I can choose for yourself. So these are 2 basic courses I wanted to share with you, that unique and AMMRCOG 10 weeks for FAB student. So I think that's all for tonight, and take good rest. Again, do not take this exam for granted. You have to perform at least 1 to 3 stations daily. It is a compulsion which you have to make for yourself. Okay. So I think that's all for today, and bye-bye.
Thank you.
Good night, everyone.